Hello, and thank you for joining us today. The video that you are about to watch discusses ventilator adverse events and improving patient outcomes in intensive care. Your presenters for this educational activity are Dr. Yepes Hurtado, Jennifer Wollaston, Jason Hunter, Elisa Cagle, and Nicole McClure. In order to get credit, you must stay for the entire presentation and complete an evaluation at the end in order to receive your contact hours. We have no conflict of interest or commercial support to disclose, and UMC Health System is accredited as a provider for continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. These are the presenters that you will be listening to today. Dr. Yepes Hurtado, the Associate Professor for Pulmonary Critical Care Medicine and Internal Medicine at TTU HSC. Jason Hunter, the MICU Clinical Instructor. Elisa Cagle, also an MICU Clinical Instructor. Jennifer Wollaston, Assistant Director of Infection Prevention. And Nicole McClure, Respiratory Therapy Educator. At the end of this presentation, you will be able to identify 3 common contributing factors to ventilator-associated events, provide guidelines for correlation of FiO2 and PEEP for ARDS patients, identify 2 appropriate nursing interventions that reduce the likelihood of VAE, and review the effects of biofilm and the stages of formation. One of the reasons for this educational activity is the fact that UMC has had VAE rates for the past 4 quarters that have exceeded our national benchmark. We utilize NDNQI for our benchmarks, and as you can see from the graph below, each of the 4 quarters displayed, we have exceeded our national benchmark.
A ventilator-associated event is defined by the Centers for Disease Prevention and Control and the National Healthcare Safety Network as an event associated with the ventilator that may indicate a change in the patient's condition. The patient must be on the ventilator for over 2 calendar days and then have a worsening oxygenation or an increased ventilator demand. To meet an IVAC, the patient would need to have an elevated WBC or a temperature present, and then a new antibiotic started and continued for 4 calendar days. Next, to be a possible VAP or a possible ventilator-associated pneumonia, the patient would need to have positive microbial testing such as a culture.
Hello, I'm Dr. Yepes Hurtado. I'm one of the associate professors at Texas Tech University Health Sciences Center in Pulmonary and Critical Care and Internal Medicine. We are going to be presenting a handful of cases and opportunities to improvement that came up after a review of a handful of cases during the last 6 months that trigger a ventilator-associated event. Here's patient number 1. This patient presented on June 30th. It was a 76-year-old female with suprapubic catheter that was changed 3 days ago. Presented to the emergency department with intermittent fevers for 2 to 3 weeks and burning vaginal pain with a past medical history of hypotension, hypothyroidism, recurrent ESBL UTIs, atrial fibrillation diabetes, and she had a suprapubic catheter in place. Her vital signs were remarkable, having some adequate blood pressure and good oxygenation. Otherwise, the chest X-ray had a bilateral opacity that was consistent with some atelectasis and some pneumonic changes. She received antibiotics promptly in the emergency department, and the initial presentation did not show any leukocytosis. On day 1, she was admitted to the med-surg with a diagnosis of UTI, diabetes, hypertension, atrial fibrillation, and the atelectasis noted on the X-ray. However, on day 3, the patient was transferred to the ICU with hypoxemic respiratory failure, ended up intubated at night with an initial tidal volume of 350 milliliters with an FiO2 of 60%, AC mode, a respiratory rate of 16, and PEEP of 5. She was identified to be also COVID positive. So here we have two different graphs, one showing the PO to FiO2 ratio and the initial PEEP that the patient was treated with. Originally, the patient had a PaFiO2 ratio that was 2 or close to 2, with an initial PEEP of 5 that was deteriorating over time, triggering an event on July 7th, where due to the decrease in PaFiO2 ratio, the patient required more PEEP, an escalation of PEEP from 5 to 8, triggering a ventilator-associated event. So if we analyze this case, we have a post-intubation PF ratio that was decreased severely at 1.5. Remember that PF ratios less than 300 are considered very abnormal. So the initial oxygenation assessment of this patient shows us that the patient was in severe respiratory compromise. We could have had an intubation that initially targeted a PEEP that was higher for this patient, with a PEEP that was recommended by the guidelines of at least 8 to 10 centimeters of water. So that's an opportunity that we can potentially change in our practice to improve the adherence to the guidelines. ARDS was recognized in the chart, but the patient continued to be treated under PEEP of 5 on day 2. There was a delayed application of standard settings that actually could be done a lot earlier when we identify that the PF ratio of this patient is declining. So we can choose on these patients to use a low PEEP strategy or a high PEEP strategy that will recommend us their PEEP of 10 if we choose to go with a low PEEP strategy, or if we used to go high PEEP strategy, we can recommend a PEEP of up to 20. Remember, the patient's PEEP was set at 8. So thankfully, this patient disposition was to an LTAC on high-flow nasal cannula after successful extubation, and the patient spent 20 days on the ventilator. So we can go back and review a little bit the ARDS protocol and the current recommendations for ventilation of patients, and we like to choose volume assist control mode as an initial mode, ideally, and set the tidal volume to 6 mils per kilo of ideal body weight or predicted body weight, which in this case that we just reviewed was adequate for the patient's weight. We need to monitor our plateau pressure and try to keep it under 30 centimeters of water, and check, obviously, if the patient has changes on compliance that can make this plateau pressure increase or decrease, or if we have the evidence of developing auto PEEP. And as an initial recommendation, we're going to see over the course of our review that many times we are choosing a PEEP that is not necessarily in accordance to the need of oxygenation for the patient. If we intubate a patient, many times we're intubating them with an FiO2 that is much higher than 50% after they have failed other methods of oxygenation, such as high-flow nasal cannula or non-invasive ventilation. So for those patients, maybe we should consider an ideal initial PEEP that is higher than 5. And this could not only treat the patient much better, but not necessarily trigger a ventilator-associated event. So after intubation of the patient, we should choose our PEEP, hopefully according to the guidelines, a very conservative ideal body weight with monitoring of fluids, lung compliance, and everything else that is involved into the ARDS standard of care. Now we're going to jump to patient number 2. The second case is a 59-year-old male that presented to the emergency department with shortness of breath and anxiety for 4 hours prior, with a past medical history of hypertension, coronary artery disease, heart failure with an ejection fraction of 40%, and polysubstance abuse. So in this case, we have an original PO to FiO2 ratio that is adequate with value of 2.8 approximately on admission, but as the patient oxygenation deteriorates and needs intubation, the patient reaches a PaFiO2 ratio of 1. Original PEEP after intubation for this patient is set at 5, but shortly after is followed by a change to a PEEP of 10. This triggers a ventilator-associated event, similar to the case that we just reviewed before. Now here's our third case. This is a 42-year-old male that presents to the emergency department with status epilepticus and has history of alcohol abuse, with the last drink being 3 days ago. And upon arrival, the patient continues to be in status epilepticus, is quickly intubated, and the past medical history of the patient is unknown. In a trauma patient, the patient is evaluated with a CT of the head that demonstrates a left parietal subdural hematoma and is quickly admitted to critical care unit after intubation. The initial ventilator settings are chosen with a tidal volume of 500, a respiratory rate of 18, a PEEP of 5, a pressure support of 10, and please note that the patient's mode is SIMV. The possible working diagnosis is septic shock secondary to aspiration pneumonia that is confirmed after culture shows gram-positive cocci chain, clusters, and gram-negative rods. The patient thankfully is extubated on 9/12 and is reintubated shortly after, requiring now a higher PEEP. So here we have our graphics, and if you notice, the FiO2 was quickly increased after September 13th from 40% up to 100%, triggering an IVAC. The patient's original oxygenation based on PF ratio was declining, although it was very good on admission with a PF ratio of close to 5. Quickly deteriorates to less than or nearly 1 on 9/11 of 2022. And you can notice that the PEEP is not changed. PEEP continues with a low value. The patient also was on SIMV, triggering an initial PCO2 decline as low as 20. SIMV in this patient that is seizing is probably causing triggering of unwanted breaths delivered to the patient. So the opportunity for improvement in this case involves maybe choosing a different mode of ventilation, as SIMV mode can potentially be triggered by the seizing patient, creating a false triggering event. There's also, on day 2, we could have had an initial PEEP correction that was higher, considering that the patient PF ratio was very low, and we require a high oxygenation via FiO2 administration only. The patient had a very short period of recruitment. If we see that on day 3, the patient had a PEEP increase from 5 to 12, but very, very shortly, for just 24 hours, before decreasing that PEEP again to 5 centimeters of water. And we expected that the patient was recruited then. That was followed by an extubation of this patient. We reviewed the weaning parameters on this patient, and the patient was extubated with great weaning parameters. But very quickly, the patient did recruit it and ended up requiring another intubation with a higher PEEP. So this brings us the problem of maybe early weaning of PEEP after a very short recruitment period. Thankfully, the patient was extubated and sent home after 14 days on the ventilator. Now our fourth patient is a 61-year-old male that comes to the emergency department from rehab, already with hypoxemia and receiving non-invasive mechanical ventilation. This patient arrested upon arrival to the emergency department, receiving 3 rounds of ACLS, intubated, and started on vasopressors, transferred to the ICU for continuation of care. The initial PO2-FiO2 ratio is really low. The patient's intubated with 100% of oxygen and a PEEP that is around 8 centimeters of water that is quickly escalated to meet the patient's oxygenation demand to levels above 15. The response is to decrease FiO2, which is appropriate. The patient's PO2 ratio improves, and the patient's hypotension continues to improve. However, based on this improving oxygenation, a decision is made to quickly decrease the PEEP from levels of above 15 to as low as 5 centimeters of water. We can see here that hypotension is not one of the triggering events to lowering that PEEP that aggressively. And also we can see that because of this lowering on PEEP and the recruitment of the patient very quickly requires escalation of FiO2 to levels of 90%. That also triggers a ventilator-associated event. You could say that maybe a less aggressive de-recruitment of the patient by lowering the PEEP in a more delicate manner could potentially prevent this problem. So as previously mentioned, there was a quick decrease in PEEP from 17 all the way down to 5 centimeters of water. That can be an opportunity to improve. If we need to lower the PEEP, maybe we can do it in a more stepwise manner. There's also a consideration we have to take here, and is if the patient has some hemodynamic implications of PEEP, like decrease in preload or causing some hypotension if the patient was hypovolemic. However, the decrease in PEEP was not related to hypotension as we saw in this patient. Also, again, the PEEP chosen of 5 centimeters of water does not correlate with the guidelines from the literature. At some point, the patient had a higher PEEP, higher FiO2 with a very low PEEP of 5. So we can consider here ways of titrating our PEEP in patients that are mechanically ventilated, and some of these ways that we can choose involve oxygenation improvement. Also consider maybe the measurement of esophageal pressure and transpulmonary pressures, and also the use of a pressure volume curve to find the point of recruitment and points of the recruitment. We're going to touch base on those concepts in a couple of slides later. Quickly review the effects of PEEP on our body. We know that after several studies and years of research, the optimal PEEP level for a patient has not been determined. So this is very controversial. PEEP is applied to prevent atelectasis, and a PEEP of 5 is usually somewhat supraphysiologic after we intubate a patient. In pulmonary edema, increases up to 10 centimeters of water of PEEP did not change left ventricular performance when the patients were followed with echocardiogram in one study. The PEEP in intracranial pressure can theoretically decrease the cerebral venous outflow, therefore increasing the intracranial pressure. So if you have a patient that you're concerned about intracranial pressure effect of PEEP, you can consider also the monitoring of intracranial perfusion pressure or cerebral perfusion pressure. The PEEP effect in focal lung injury or focal lung disease can also create a state of shunting by compressing the intraalveolar capillaries in the healthy lung and therefore moving that blood to the injured lung, and creates that shunt. In hypotensive patients, you have to remember that if the patient is hypovolemic versus a patient that is normovolemic. In a patient that is hypovolemic, you have an increase in intrathoracic pressure that can decrease venous return, reduce cardiac output, and potentially cause hypotension. But if the patient is adequately resuscitated and is normovolemic, the PEEP up to 20 centimeters of water is generally well tolerated. And the PEEP also decreases the afterload by decreasing the transmural pressure of the left ventricle. Some of the tools for titrating PEEP involve the most common one being oxygenation, assessed by PF ratio and oxygen saturation, but also in more complex ways with oxygen content in the blood. The esophageal pressure can be calculated by inserting an esophageal balloon, and is calculated helps us calculate the transpulmonary pressure by knowing what is the airway pressure and the pleural pressure. Several studies, 2 of them included here, have been done to see if patients have an effect on mortality. If an esophageal pressure strategy is used for titration of PEEP on patients. The initial one did show a promising change in death and on mortality on these patients. However, after the second study to corroborate the EP-VEN2 it was noted that there was decreasing need for rescue therapy, but there was no overall death changes in these two strategies. But also it demonstrated that there was a rate of barotrauma that was no different in these two patients and these two studies. The pressure volume curve can be also used, and here we have a pressure volume curve demonstrating here on the x-axis the airway pressure and the volume on the y-axis. And we have here our lower inflection point, the point at where a small change in pressure can generate a large change in volume. And here we have the point where we have the deflection point, where if we continue increasing the pressure, we may not be actually delivering more volume, and is considered a point of overdistension of the lung. So we can potentially ventilate our patients with two methods. One of them is to apply a PEEP that is very close or slightly above the lower inflection point. And the method number two is to actually see what's the compliance of the lung, or calculate what's the compliance of the lung throughout the curve by using our formula of respiratory system compliance is equal to the total volume divided by the plateau pressure minus PEEP. And try to apply a PEEP that matches the pressure at which we get the best compliance for the patient. Similarly, when we're decreasing PEEP, we can follow the pressure volume curve to do a more an approach that is more consistent with the patient's lung mechanics.
Thank you very much, Dr. Yepes. We appreciate your time and input on this important topic. My name is Jason Hunter, and I am one of the clinical instructors for the medical ICU. As we all know, prevention of ventilator-associated events requires all healthcare professionals to contribute and do their part. We are now going to focus on UMC's updated VAE fishbone and discuss interventions that nursing, as well as all disciplines, should be implementing to improve patient outcomes. Here you will see the ventilator-associated events, or VAE fishbone. The new information is shown in red. To reference the policy, it is located under DPP 512, which is found on the intranet under Policies and Procedures. Then you'd go under Department, Critical Care, Patient Care, and then Ventilator-Associated Pneumonia Prevention. First, we will discuss the insertion section of the fishbone. As nurses, we are not the ones to intubate the patient, but we do assist our physicians by providing them with the best tools for the job, such as the endotracheal or ET tube that comes with subglottic suction. They are commonly called high-low ET tubes, and that's spelled H-I-L-O. The majority of intubations at UMC include the high-low suction, unless they come from outside the hospital or they remain intubated after an OR procedure. Other equipment in the room should include a minimum of 2 suction canisters if your patient's intubated. Under the tube necessity section, it covers SAT and SBT. These stands for spontaneous awakening trial and spontaneous breathing trial. The awakening trial should occur first as the RN turns down the patient's sedation according to the physician orders. And the breathing trial is when the respiratory therapist changes the ventilator settings to require the patient to do more of the work while breathing and to determine if the patient could be successfully extubated. Our respiratory therapists, they try to do the spontaneous breathing trial every morning, and their goal is to coincide with nursing turning down or even off the sedation. And some of our ICUs even do 2 spontaneous breathing trials a day, with one being in the morning and one in the evening. The next section of the VAE fishbone we will go over is the environment section. We want to make sure that we are avoiding disconnecting the ventilator to maintain a closed suction system, which will aid in preventing ventilator-associated events. Our RTs also try not to disconnect the vent circuit because it has shown to increase the incidence rate of VAE. If a patient is going on a trip, they're being transported to the OR, CAT scan, MRI, anything like that, the end of the circuit should be covered. If the patient is away for more than 2 hours, the vent circuit actually needs to be changed. On top of trying to prevent an infection, breaking the circuit will de-recruit the patient and set them back in their therapy plan. The RT will also change out the circuit every 30 days or as needed. Ensuring the ventilator tubing is supported by a swivel arm will assist with preventing MDR-PIs, medical device-related pressure injuries on the lips. And as you can see in the image provided, make sure that there is no pressure from the circuit that's pressing against the patient's face, lips, or anything like that. Limiting suction to only performing when clinically indicated is important because performing too often actually stimulates the production of more saliva. Also, frequent suctioning will further irritate the airway. Patient positioning is also very important. You want to make sure you keep the head of the bed elevated to 30 degrees at a minimum, unless it's contraindicated. And this is to better improve the lung compliance and expansion. If the patient can't maintain the head of the bed at 30 degrees, please utilize reverse Trendelenburg, which is shown in the picture. And that way you can kind of keep the incline still at 30 degrees. The environment section is making sure we change the oral suction every 24 hours. And this is to reduce the bile burden on the whole suction setup. You also want to make sure that you keep the patient's mouth clean to reduce the number of microbes in the mouth, which in turn will reduce the bile burden as well as the biofilm in the mouth and on the ET tube. For oral care, we use the kits, which is the image on the left. Each kit is designed for oral care on patients with assisted ventilation for the whole 24 hours. And utilizing the kit in order and using all the pieces is very important. So in the picture you'll see, aside from the covered yonker, there's also the subglottic suction tube. There is a suction toothbrush as well as several suction swabs. And you should have enough for each shift, day and night, for those items. The next portion of the VAE fishbone is the education section, and on it is hand hygiene, which is extremely important. We should always be utilizing proper hand hygiene when we enter a patient's room, as well as anytime we're doing a new task with our patient. If you have a patient with a needing of a bite block, most of our patients, they come with AnchorFast guards, which it's an AnchorFast securement device that has a built-in bite block for it. But if you don't have one of those, some of our areas in the hospital will utilize an oral airway for the bite block. If you do have one of those, make sure that you take it out so that you can properly clean your patient's mouth whenever you're performing oral care, and move the ET tube as you need to before placing it back in if you even need it. Another good reason why you want to periodically take out the oral airway is because it could cause pressure injuries for your patient. The next portion of the VAE fishbone is documentation. And the first part talks about oral care and doing it at a minimum of every 4 hours as you're doing your VAE assessment. And aside from doing your oral care every 4 hours, it's very important that you document it, because we all know that if you didn't document it, it didn't happen. In the image on the left, you can kind of see an example of a VAE assessment where you're assessing every 4 hours. The patient needs max assistance, what you're using, the elevation of the head, and everything that is important to make sure that you include in your documentation. The next portion of your documentation is verifying the vent settings. And this is very important. You want to make sure that what you heard at the bedside report is what's on your ventilator, as well as what's in the documentation. If you notice that there's any changes in the documentation compared to the ventilator, make sure you're reaching out to your RT as well as your physicians. See if there's a reason for the discrepancy. Maybe someone changed it without having a chance to update it, but we just all want to be on the same page. At this time, I'm going to turn over the presentation to Elisa, who will continue the conversation over the VAE fishbone.
Thank you, Jason. Continuing on with our documentation, we as nurses need to assure that not only are we repositioning our patients every 2 hours, but that it is reflected in our documentation. As you likely know, ventilated patients are spending all or the majority of their time in bed. Turning patients every 2 hours improves blood flow to at-risk tissue and decreases the risk of pressure injuries. Progressive mobility is the practice of helping our patients achieve the highest level of mobility possible during their current hospitalization. The act of documenting what your patient is doing, even if it's just range of motion, is important because it shows that we are working towards things like preventing contractures in our long-term intubated patients and have not forgotten the end goal, which is to have them leave the hospital with as much strength as possible. Things even like pivoting to a chair, like this gentleman has done who's playing the guitar, these are all possibilities with ventilated patients. Moving on to prevention, we cannot stress enough the importance of oral care. Earlier in the presentation, you saw a picture of our oral care kits that we currently stock here at UMC. What you might not have noticed in that first package of supplies, there was a soft toothbrush and a sponge as pictured on the left, along with the cleanser and oral moisturizer that's not pictured. Please assure that you are utilizing the soft toothbrush and the sponge, not just one or the other. This soft toothbrush helps to release the bacteria buildup that lodges itself in the crevices of your patient's teeth, but it is also beneficial in scrubbing the roof and the tongue of your patient's mouth. Please do not assume that if your patient doesn't have any teeth that they don't need the toothbrush. The frequency of oral care will be established at the beginning of your shift by completing the VAE assessment task. This task should fire with all patients receiving positive pressure ventilation and will instruct nurses to complete oral care every 4 hours at minimum. Oral care should be completed every 2 hours at minimum if receiving a paralytic and can always be done more frequently than that if you feel like it's appropriate. Please assure that your patient's mouth stays clean and appropriately moist to reduce the risk of VAE. To the left, you see the tool that we use to complete subglottic suctioning if your patient does not have a continuous subglottic suction device. We will talk about that here in just a second on this next slide. Now you see an illustration to your left that shows where those potential bacterial-filled secretions are pooling at the top of the cuff of the ET tube. If those are not suctioned with the piece of equipment mentioned earlier or a continuous suctioning, with each movement you run the risk of the tube repositioning a little bit and those secretions flowing down below the cuff into your patient's lungs and causing a ventilator-associated event. That's why the quality and the frequency of oral care is so very important in the care of these intubated patients. Respiratory therapists track and document that cuff pressure at least once a shift. So if you can hear that your patient is gurgling or breathing, please find your respiratory therapist and have them assess the cuff, as this could mean that air is leaking out, that cuff is deflating, and those secretions are moving into your patient's lungs. These next two portions speak specifically to oropharyngeal suctioning. Here it specifies how these areas should be suctioned after cleaning, prior to repositioning, or whenever it is felt necessary. Currently, UMC has a high-low endotracheal tubes, as seen on the left. If hooked up to suction appropriately, they should take care of all the work of subglottic suctioning to your patient. You will attach the yellow suction lumen to your wall suction on either continuous suction at 20 millimeters of mercury or intermittent suction at 150 to 200 millimeters of mercury. Please do not assume that it is always working correctly. There could be large secretions collecting in the lumen that you will need to manually extract from time to time with an empty syringe. CHG mouthwash is recommended twice daily during oral care to decrease the buildup of bacteria in the mouth. A crucial piece to keeping your patient's mouth clean is assuring that each and every time you use the disposable suction piece in your patient's mouth, you rinse it out. This ensures that it is clean and ready to go the next time you need it. Do not forget to slide the protective sleeve over it. This ensures that no bacteria is able to cling to the piece of equipment that you're later going to put in your patient's mouth. We spoke a little bit about repositioning earlier, so we're going to gloss over that. Very important that we do not lavage our patient's ET tube without an order. It used to be common practice to insert fluid into our patient's lungs in order to thin out those secretions and to suction them and make it easier. While it was somewhat effective, it also came with increased risks of ventilator-associated vents, and the practice has since been discouraged. Very important that we know that AVAPs and BiPAP also follow the intubation policies and procedures for oral care. So we're needing to clean their mouths every 4 hours as well and not forget about them just because they're not intubated. Here is another example of progressive mobility being implemented on an intubated patient. Getting our patients up and moving as much as they are able to and as early as possible will greatly decrease the risk of ventilator-associated events. If your patient can only tolerate sitting in high Fowlers or chair position while laying in bed, let's try to make sure that our patient gets that opportunity. As the patient is able to tolerate that position for longer, let's consider sitting them on the side of the bed. Changing positions frequently, along with incorporating progressive mobility, have proven to have many positive outcomes. When utilized together, they aim to decrease the formation of pressure injuries, improve the movement of phlegm in the lungs so that it can be more easily coughed up, decrease the risk of muscle wasting, and ultimately decrease the length of stay. Next, Jennifer will talk to you about biofilm and its impact on ventilator-associated events.
Thanks, Elisa. Many prevention measures that we have discussed aim to reduce biofilm. So what is biofilm? Biofilm is a reservoir for multiple pathogens to persist by providing a protective matrix. It is a 3D structure with extracellular polymeric substance that creates an ideal environment for chemical reactions, nutrient entrapment, and protection against external threats. This EPS even protects the microorganisms from the immune system response and antimicrobials. Many hospital-acquired infections are linked to biofilm formation on medical devices, such as endotracheal tubes, urinary catheters, and vascular access devices. You can see in the figure to the right that biofilm starts as a single free-floating bacteria, which multiplies and grows and starts biofilm formation. The biofilm matures and then breaks apart, releasing colonies to colonize in other areas of the body. It is believed that high-grade biofilm or mature biofilm formation on endotracheal tubes has been associated with development of ventilator-associated pneumonias, or VAP. Biofilm forms on endotracheal tubes within 24 hours. Endotracheal biofilm contains populations of multiple bacteria, and studies have shown that up to 70% of ventilator-associated pneumonia patients have lung pathogens that match the biofilm on the endotracheal tube. As previously discussed, there are some simple strategies to prevent biofilm formation. Effective oral care helps prevent biofilm formation. Subglottic suctioning, when indicated, removes secretions that contribute to biofilm formation. And effective management of ventilator tubing helps prevent biofilm formation within the ventilator system. Next, we'll have Nicole McClure, our respiratory therapist educator, to talk more about respiratory recommendations.
Thank you, Jennifer. I'd like to make some final recommendations from a respiratory therapist standpoint. Of course, to avoid VAEs, we really do want to try to keep the patient from being intubated at all. It's the easiest way that we can help to do this. Some adjuncts that you can use prior to intubation, of course, is your high-flow nasal cannula. This offers some extra flow and a little bit of extra pressure to help keep the patient from having such a high work of breathing. AVAPs and BiPAP are also non-invasive forms of ventilation that can also be utilized to keep the patient from being intubated. Early use of these and early implementation is going to really help your patient from being intubated and ultimately staying on the ventilator. In private, we can also have interdisciplinary conversations about maybe taking a DNR, DNI route, or maybe comfort care measures if the ultimate end goal does not look well for the patient. We work as an interdisciplinary team, so it is nice to get together at the bedside and discuss all the options prior to intubating the patient. If you do have to end up intubating the patient, of course you want to try to limit their days on the ventilator. We want to try to be advocates for them, especially for the bedside nurse or therapist, trying to push for spontaneous awake trials, spontaneous breathing trials, being very aggressive, maybe trialing multiple times a day, really just trying to push for extubation as much as we possibly can. Progressive mobility is also a fantastic tool, as previously discussed in detail, for getting your patient up, mobilizing those secretions, helping them clear their airways, and being part of their care to get better and off the ventilator. Minimizing sedation is also very important. As a therapist, this is something that we can communicate with our nurses, ask questions, make sure that we're just assessing all our options to get the patient up and awake and hopefully liberated from the ventilator quickly. In summary, prevention measures are key in limiting the incidences of VAEs. Bedside report and verification of vent settings is very important for all interdisciplinary team members. This helps to keep everyone on the same page and ensures the patient is getting consistent care. Proper utilization of equipment such as high-low ET tubes or airways is also beneficial. Proper cleaning techniques and the use of subglottic suction helps to remove any harmful secretions. Environmental considerations such as patient positioning, ventilator circuit changes, and use of ventilator arms are all crucial to keeping the airway as clean as possible. Only suction when is indicated. Suctioning causes irritation, which ultimately causes more secretion production. Lowered SpO2s and increased airway resistance are examples of indications for suctioning. Routine oral care and complete oral care. Following the proper guidelines for oral care is important in preventing the growth of harmful bacteria. Progressive mobility is a great opportunity to get your patient up and those secretions moving. Being an advocate for your patient is also extremely important. Be encouraging of aggressive spontaneous awake trials and spontaneous breathing trials.
Thank you so much for watching this video. We appreciate every effort you make to improve patient outcomes. If you have any additional questions, please contact one of the presenters at their email, which is listed for you below.